This is Patrice Wendling at the annual meeting of the American Society of Hematology, speaking with Dr. Kumar, who's just presented results on a new all-oral combination for patients with newly diagnosed myeloma.
Patients with myeloma are living a lot longer than what they used to. So talking about median survival of 8 to 10 years compared to 3 years from a decade ago. Now, most of these improvements have been because we have new drugs like the proteasome inhibitors and the immunomodulatory drugs. Now, with patients living longer and longer, I think they're having a better quality of life. So I think the attention has now kind of diverted to developing regimens which are more tolerable, which is least intrusive on the normal day-to-day life. So I think from that standpoint, the ML9708 is perfectly placed to develop to be able to be combined into regimens which are highly efficacious but at the same time better tolerated. Now, the proteasome inhibitor Velcade combined with Revlimid, which is an immunomodulatory drug, has been a very effective combination for this disease, both newly diagnosed myeloma and relapsed disease. Now, one of the two problems with the Velcade-based combination has been it is injectable, so you have to go to a physician office to get it. And second thing is it is associated with peripheral neuropathy. So when the ML9708 was being developed, what was clear was that it appears to have reduced neurotoxicity compared to what we have seen historically with Velcade. And second thing, it was bioavailable orally, so you can just take a pill a day instead of having to go into any physician office and get an injection. So it seemed logical that we want to try and maximize this benefit in the combinations which have been the most effective. So we basically looked at the same combination, which is the proteasome inhibitor, except here we are talking about ML9708 in combination with lenalidomide and dexamethasone. So that regimen that is efficacious, much more convenient, but at the same time more tolerable so that patients can potentially stay on it long term.
What was particularly noticeable was the lack of peripheral neuropathy.
Right. And I think that is probably one of the key things about this drug. Now, the peripheral neuropathy with Velcade, again, it ranges quite a bit between different studies, but a significant proportion of patients ended up with peripheral neuropathy, especially after prolonged therapy. Now, in the initial phase 1 trials with this drug used as a single agent, there have been no grade 3 neuropathies that have been reported. In this combination that we studied in this clinical trial, we did see 2 patients out of the 65 who developed a grade 3 peripheral neuropathy, but both patients went off therapy and those symptoms improved, and one completely resolved and one has gotten down to grade 1.
How do you see this being used? How do you foresee this being used in the future as a building block after patients have failed on the Revlimid combination?
I think it will have use in both places, just like the Velcade Revlimid Dex combination is being used both in the upfront setting and in the relapse setting. This would essentially be positioned in the same places, except this is going to be more convenient compared to what we are doing with the Velcade Revlimid dexamethasone. Now, clearly, the phase 3 trials have in the newly diagnosed and in the relapse setting have to be available before we accept this as a routine therapy.
As we see in this fiscally austere environment, what are we looking at in terms of cost?
So again, this is something we struggle with every day, with the rising cost of cancer care. And I think it is more important that we try to understand which patients benefit the most from the more expensive therapy. And I think in myeloma, the field is moving towards that. We are starting to understand that myeloma is not one disease, it's multiple diseases. And I think in the next few years, we're going to have a better understanding about which patients really need all these medications given in a combination compared to some other people. Maybe it's a standard risk multiple myeloma where we could use one, keep things under control for a few years, move on to the next. So it will be like treating diabetes or high blood pressure. Whereas there are patients who are high-risk myeloma, who are very aggressive disease. Maybe we need to put all the forces to bear to actually try and control the disease early on.
Based on your cytogenetic analysis, did you see anyone in particular in whom this would be very beneficial, or you'd really want to start with this combination?
So with this particular study, there were very few patients to make any kind of such assumptions. But one thing we need to be clear about is that patients with high-risk multiple myeloma always respond as good to any therapy as patients with standard risk multiple myeloma. The difference is that the treatment effect does not last long enough in the high-risk multiple myeloma patients. So clearly this study is very early on in terms of the duration of follow-up to make any kind of judgments on that. But we know from the studies that have been done in combination with using the bortezomib combination that patients with high-risk disease, especially when they're given long duration of bortezomib therapy, they do gain much significant benefit from being on that drug.